Hello everyone and welcome back to Pharmacology with Dr. Sokolow. So today we are going to talk about the second step of pharmacokinetics. So if you remember, there are like four steps in pharmacokinetics. The first one is absorption, the second one is distribution, the third one is metabolism, and the third one is excretion. And so in the last module, we talk about the parameter that can affect the absorption of a drug. And today we're going to talk about the parameter that can affect the distribution of a drug. So the first one is going to be the blood flow, and the second one is going to be the plasma protein binding. So the blood flow, because it's the first phase of distribution, the drugs, are carried by the blood to the target. Let's say a drug is carried to the heart if the heart is the target. And so the blood flow is going to determine the rate of distribution. And once the drug reaches the target, the drug has to exit the vascular system. And so to exit the vasculature, they have to exit, the capillary bed. And if you remember from the last module, we talk about, the capillaries having those little gap in between cells, and that doesn't really constitute a barrier to absorption when it was going from the GI to the circulation. And here you have the, going from the circulation to the target organ. So it's the same thing. It doesn't really constitute a barrier to be transferred to the target site. Now, there is an exception, which is the blood-brain barrier, and we're going to talk about this one in the next slide. And then we're also going to talk about, the placental drug transfer and why, some drug cannot be given to pregnant women because it can affect the fetus. And the last step that is going to affect the exiting of the vascular system is the protein binding. And again, we're going to see this in the upcoming slides. So first, let's talk about the blood-brain barrier. So as you can see here, there are like tight junction in between cells, and therefore the drug cannot go through those tight junction that they will do on a regular vasculature, on a regular capillary. So when they are in the blood-brain barrier, and because the barrier really protects the brain from being attacked by chemicals, this is a strong, protection for the brain. And so therefore, for those chemical, and in this case for drugs to be going into the brain, they have to be lipophilic. They have to be lipid soluble drugs in order to be able to cross the blood-brain barrier. Now, for the placental drug transfer, and the reason why so many drugs can be can be transferred from the placenta to the fetus, is because the placenta is just like the membrane of the placenta is just like any other membrane, and so you have the same rules that apply. The drug, if it's a drug that is lipid soluble, which is most of the case for the drug is going to be able to cross the membrane and then therefore reach the umbilical vein and be distributed to the fetus. And so that's where you have some risk with those medication. But of course, there are some medication that the mother needs to take while she's pregnant, and there is no other way that she can avoid, because it's for her own safety and her own health that she needs to take those medication. But some can be transferred to the fetus. And so the last things that is going to influence the distribution of a drug is the protein binding of a drug. So you know that the plasma has a lot of protein, and the main protein is the albumin. And so drugs are actually binding to the albumin to be distributed. And only the free drug, so the drug that is not bound to the albumin, is the one that is going to be able to exit the vasculature and reach its target on, the target organ or the target cells, and reach the receptor. So as you can read here, only the unbound drugs are distributed to the tissue. And also the protein binding is reversible. So you have, you see here, you have an equilibrium between how much drug is bound to the albumin and how much is free. And you have some drugs that are actually more likely to bind stronger to the protein. And in that case, when you have a patient who is polymedicated and is taking two drugs that can interact for the same site of binding on the albumin, you can have a drug interaction, and that can lead to some increase of the adverse effect. And I'm going to talk about this in the next slide. And also the protein binding is going to prolong the half-life. It's going to prolong the time that the drug remain in the system, because the drug is going to be released slowly from the protein, and then, of course, it's going to go through the body slower than the drug that is not heavily bound to the protein. So here is the example between a drug that is weakly bound to the protein and a drug that is highly bound to the albumin. So as I said, you only have the free drug that can exit the vasculature and reach the target and induce an effect. And that's going to be the same thing for the next step of pharmacokinetic, which is the metabolism or biotransformation. And it's going to also apply to the last step of pharmacokinetic, which is the excretion. And so this is going to translate when you're going to look at the plasma concentration over time. You can see that you have a high peak, but then the time that the drug remain in the system is pretty short. The reason why is like the drug can, exit the vasculature, um, have their effect, but it can also exit and be degraded in the system and excreted. So that's why the time that the drug spend in the body is way shorter than a drug that is strongly bound to the protein. Because you see here, the drug that is strongly bound to the protein are going to be slowly released into the vasculature, but also it's going to be slowly biotransform or metabolize, and we're also going to be slowly excreted. So if you compare the green arrow to the blue arrow, you see that the green arrow are much narrower, and which means you're going to have less concentration of the drug in the body, and that drug is going to stay much longer if you look here on the second graph. But, and then as you can see, you see that you have a high concentration of the drug that is bound, and so little by little the bound drug is going to be released and exert its effect. Now, as I mentioned, you can have interaction for those protein, and so if you have two drugs that are given and are competing for the protein, and one can displace the other, so which means you're going to have drug A that is going to be released sooner because drug B is going to try to get a site on the protein. And if drug A is released faster from the protein, that means it can also exert its effect on the receptor and on the site of action. And so that can cause, an interaction between those two drugs, because you're going to have drug A that is going to act faster on its receptor and can cause some toxicity. When we're going to talk about drug interaction in another chapter, I will re-emphasize this concept. But for now, I want you to understand that only the free drug can exert its effect on the target, and only the free drug can be excreted, and only the free drug can be metabolized. And that's it for this second step of pharmacokinetics, and I'll see you soon in the next module.